Thank you, Ramesh. I started sharing. I don't know if you can see it.
Yes.
So thank you, Ramesh, for the introduction. Thank you, Imad and Vladimir, for continuing your effort and putting all these fantastic webinars together. And I was privileged by Professor Imad Kanan today to talk about limbic system anatomy and surgical planning, especially in tumor-related epilepsy. And let me start with something very emotional for me. I am sure I wouldn't be here today, and I wouldn't reach the experience I'm reaching without the year I spent in Istanbul, Turkey, under the supervision of Professor Toure. He really changed the way in which I think. He really changed the way in which I see our specialty, and you can understand how happy I feel today to share this panel with him. I will just share with you some concepts that I truly got during my stay in Istanbul. So I cannot thank you enough, Professor Toure, for all your help during that year. Indeed, most of the cases and the anatomical dissections I'm going to share with you today are mostly inspired on my work there. Well, let's start with the limbic system, and the word limbus. This is the first concept I learned, means the edge. In this case, it means the edge of the hemisphere, because all the limbic and paralimbic structures, as we will be discussing today, are located in the interhemispheric fissure and in the basal aspect of the hemispheres. And this is not by accident. This has been happening during 500 million years. And the stress for the survival, the environment, and the mutations have been changing our central nervous system. So the limbic and paralimbic areas have been pushing by the telencephalic tremendous development to this edge of the interhemispheric fissure and the mediobasal aspect of our brain. So this is how it looks like, and this is a diagram which is coming from Professor Yasser Hill's book, in which we can see the most important structures from the limbic and paralimbic lobes. This has been always confusing for me, but there are some texts like this one in which the different structures are classified according to the different layers of neurons and the development of these ones. So we can have olfactory and hippocampal areas on the limbic lobe, and parahippocampal cingulate areas on the paralimbic lobes, and also some areas which are located in the insula, in the orbitofrontal cortex, and also in the temporal pole, which are closely related with this paralimbic lobe. So why is it special? It's special for many reasons. The most important one is the different phylogeny of these regions, but also we can see that the vascularization and especially the pattern of the arrangement of the fibers is very special on the limbic lobe, because all the fibers located here are arranged like a belt, like a semicircular belt. So that's mainly because of the tremendous development of the diencephalon, which has been pushing these fibers away from their origin. That's why most of these fibers are arranged like this. And something very important is also the pattern of connection between the both hemispheres, which is mainly coming from the anterior commissure. So if we try to summarize the most important areas of the limbic and paralimbic areas, we can have the mesocortical, proisocortical, and allocortical regions, which belong to the paralimbic and limbic lobes. And I will try to share with you some cases of tumor-related epilepsy on these different areas. Let's start with a region which is not purely limbic, but paralimbic, which is the anterior aspect of the insula, the anterior lobe of the insula. And this is a 31-year-old lady who came to our clinic with seizures, which were quite well controlled with anti-epileptic drugs and some personality disturbances. So we can see a tumor which is mainly located, as you can see here, just around the lumen insula, which is the area connecting the insula with the perirenal and renal cortices. But you can see how the posterior aspect of the insula, the long gyri, are completely preserved and pushed posteriorly. So this is a purely tumor located in the anteroinferior aspect of the insula. So this is mesocortex, and this is part of the paralimbic lobe, mainly located in this area here. So how would you approach these tumors? We have to try to think on an approach which will release the pressure and will give us the chance to resect as much as possible of this insular tumor. As you can see, this purely insular tumor has opened the fissure for us. So this is a perfect case for a Transylvian approach, just splitting a little bit and opening the arachnoid on that layer. Important issues to consider are the location of the fibers surrounding this tumor. So we have the arcuate posterior superiorly, and we have to imagine where the corticospinal tract is located. In yellow, we have the arcuate, and here we do have the IFOF, which is really important, especially in this dominant hemisphere for language purposes. So that's why, again, a Transylvian approach is going to be something quite safe for our patient. So as we will see, we start just opening this arachnoid, and the tumor is right there. So we can work in two windows, temporal or frontal in this case. So what we do, and this is one of the first things I learned in Istanbul, try to debulk and do the compress as much as we can the tumor, and then look for the limits in the superior peninsular and inferior peninsular sulci. As we are moving posteriorly, there is always a dangerous area, which is the most posterior part of these tumors, very close to the corticospinal tract, exactly here, which is something that we should be very careful about, because the corticospinal tract is quite close to this part of the lesion. Let's move to a different one. And now we are moving to a different limbic, especially paralimbic area. So here we do have the lumen insula, which was the place where the tumor was growing. And now we are moving, as you can see, this tumor is not only growing in the insula, but also invading the temporomesial area and also the fronto-orbitary gyri. Also, the gyrus rectus is completely preserved, and also the neocortex of the temporal lobe. So this is a perirenal region, mainly located in the rhinencephalon, quite close to the anterior perforated substance. And why this tumor is spreading like this? Thanks to this uncinate fascicle, which is connecting the temporomesial with the fronto-orbitary gyri. So this is a tumor which is mainly located in the antero-infero insular, in the posterior orbitofrontal gyri, and also in the temporal pole, especially in the temporomesial regions, mainly located in the amygdala and head of the hippocampus. So this is a paralimbic tumor, and in this case, there is no way to go Transylvian. In my short experience, it's much better to go transopercular, because the tumor is invading the frontal operculum. In this case, I try to split the Sylvian fissure, as you will see, in order to face the tumor, but finally I decided to go through the temporal pole through T1 in order to reach it. So this is the right pterional craniotomy. We are opening the dura, releasing some CSF after opening the fissure, and then we place our electrode to control the corticospinal tract. We try to open a little bit the fissure, and finally we start our cortisectomy in the so-called planum polare, and here we are reaching the temporal pole through this transopercular resection. This is the insula itself after removing the temporomesial aspect. This is P2, so this is the uncus, and this is the tentorial incisura, so it means that we reach the amygdala and the head of the hippocampus, and now we are moving to the fronto-orbitary gyri. Through the basal aspect of the pars orbitalis, we are entering the tumor, and we are going to try to connect both structures. Here we have the carotid artery with the lenticular striate arteries, and this uncinate fascicle should be over there, connecting this fronto-orbitary with the temporomesial area. And the uncinate is indeed completely invaded by the tumor. Now I'm moving again to the temporal window, where I want to resect the head of the hippocampus in order to try to control the scissors of this patient. And this is the final result. The patient was doing quite well, although he had a very small infarct on the internal capsule, which luckily was not clinically important. But what I want to show you in this post-op is that we have removed the part of the insula, we have removed the temporomesial aspect, amygdala and the head of the hippocampus, as well as the temporal pole, and also the posterior aspect of the fronto-orbitary gyri. But we are sparing the neocortex of the temporal lobe, the parahippocampal gyrus, and also the gyrus rectus. So we are mainly removing the posterior aspect of the orbitofrontal gyri, which indeed is the area where this glioblastoma was growing a few months ago. This is a young lady, if I remember well, 57 years old lady who had this tumor with headache and very important personality disturbances. And the tumor, as you can see, is mainly growing from the posterior fronto-orbitary gyri, invading probably the septal region and pushing the cingulate gyrus, as I will try to show you after the resection. So this is clearly a tumor located in the posterior orbitofrontal gyri, and maybe invading the olfactory and septal regions in the most posterior aspect of itself. So it's a paralimbic limbic tumor. In this case, the approach I chose was at the subfrontal one. So this is a quite unifrontal lateral supraorbital approach. We are approaching the base of the frontal lobe. So we identify the fronto-orbitary sulci. And now we start our resection, trying to debulk as much as we can of this tumor. This is a small craniotype, but it's going to be, as I will try to show you, very, very interesting in order to deal with the most medial and the most lateral part. This is the optic nerve. This is the olfactory nerve, which was completely surrounded by the tumor itself. And this is the Sylvian fissure seen from the frontal aspect. Now we are again moving to the most posterior part, trying to separate the olfactory from the optic nerve. This is the carotid. And here we will see the most posterior aspect of the tumor in contact, close contact with the Sylvian fissure and also in the interhemispheric fissure. So this is the contralateral gyrus rectus, that's A2. This is the optic nerve I'm cutting right now. And here we have a nice view of the interhemispheric fissure with both A2s. This is the final view after the resection. And this is why I want to show you the post-op is that the cingulate gyrus, which is part of this limbic lobe, is completely preserved by the tumor, and here it was just compressed. So it's an important concept to try to understand. This is where the tumor was growing, mainly posteriorly growing to the septal region, but here we can have a tremendous number of different cingulate tumors, which mainly are approached from an interhemispheric approach in order to reach the cingulum. We can go ipsi or contralateral, whatever we feel more comfortable with. And this cingulate and parahippocampal tumors are made of periarchic cortex, which is mainly paralimbic lobe. So cingulate, most of the cases, an interhemispheric approach is the ideal one. But as you can see, the cingulum is continuous from isthmus with the parahippocampal gyrus. And there is a very important difference. Once we are moving posteriorly from the cingulate to the parahippocampal gyrus, this gyri is moving laterally and inferiorly. So the interhemispheric approach is not gonna be enough in most of these cases if we want to reach the most anterior part of the parahippocampal gyrus, as we were facing into this case. So this is a tumor which is mainly growing in the parahippocampal gyrus, as you can see, but also invading the hippocampus and partially the most posterior part of the parahippocampal gyrus in connection with the isthmus of the cingulum. So this is a tumor which was growing in these two different functional areas. And for this purpose, this is the anatomy we must try to preserve as much as possible. The eye of especially in the left hemisphere, the optic radiations, it's much better if we try to avoid crossing them. So that's why, and I learned again this concept in Istanbul, the ideal approach is a supracerebellar transtentorial approach. So as you can see, these are two important limbic belts that I want to mention right now. The external extraventricular belt, which is the belt made by the cingulate fibers and the parahippocampal fibers, with an input of information through the olfactory nerve connecting the amygdala and the septal regions. And this is where the tumor is growing through. But also we have an intraventricular belt made by the hippocampus with the fornix, and finally the circuit of Papez connecting the fornix to the mammillary body, and finally spreading through the mammillothalamic tract to the anterior nucleus of the thalamus. And this is where the tumor is growing. So the tumor is growing in two different limbic belts. So that's why this approach is fantastic in order to remove a tumor like this. So this is the kind of incision. This is in sitting position. We have a view similar to this one. And after opening the tent, we can approach, and we published recently, this is how I do it with Roy Daniel in Acta Neurochirurgica. So this is the technique. Again, I learned from Professor Ture, semi-sitting position. We try to release CSF from the cisterna magna, and we place always a cotonoid there. We try to open the dura as much as possible towards the transverse sinus, and then we retract it superiorly in order to open the supracerebellar space. And you can see how by capillarity, this cotonoid from the cisterna magna is helping us to release the pressure. Then we place a cotonoid in order to identify where we could do the opening of the tentorium, and that was an ideal point. So this is how I learned to do this. We open the tent in this L-shaped fashion that Professor Benes is always explaining us in hands-on cadaver courses. We have a look with the endoscope in order to make sure that we are not going to damage mainly the fourth nerve, which is quite posterior, but maybe we could have some variations. And then we attack directly the parahippocampus. We start debulking, taking some tissue, and this is the hippocampus, already posterior aspect of the hippocampus, as we have been crossing superiorly the parahippocampal gyrus. This is the choroid plexus. With the endoscope, we can even reach different or difficult regions, and we are entering through the temporal horn. Here we have the ankle recess, which means that we have reached the head of the hippocampus, and we are leaving behind the amygdala, as I have no longer instruments in order to deal with that. Let me show you this special case. This is a patient I had in 2013 when I came to Alicante. He's a bullfighter, professional bullfighter, and he had this tumor mainly located, as you can see, in T3, fusiform, and parahippocampal gyrus. T1, T2 are completely intact. I had some doubts about the subiculum and the dentate gyrus, but if you have a look here, it looks like it's not invading the amygdala. In this case, I couldn't think on something different at that time than a transcortical trans-T2 temporal lobectomy. And this is the final view we can get after removing the amygdala, which was supposed to be here. So this is the carotid PCOM, P1, P2, the tentorial incisura, and the third nerve. And we tried to remove as much as we could the hippocampus, because the patient was having very uncomfortable seizure. This is the post-op image 8 years later. He's doing fine. He's doing so fine that he wanted to come back to his normal work. And I insist on him that he should not, this is the visual deficit he's having, but he told me, Pablo, unless the bulls start flying, I will not stop my job. So I couldn't complain about that point. And this is a special case we did during the pandemic time. This is a 71 years old lady with very uncomfortable seizures, and you can see this tumor invading the temporal lobe, the neocortex, but also the amygdala, as you can see here. And maybe this is the ankle recess, also the head of the hippocampus. But the thing is that she was having very uncomfortable seizures. So this is a tumor mainly growing in the temporal pole and also partially the amygdala. Had some doubts about the hippocampus. So it's a limbic paralimbic tumor, also invading the neocortex. So this is where the tumor is growing, and this is the scheme we try to get in our mind. The ancus anterior aspect is the amygdala, and the parahippocampal gyrus is completely free of tumor. So it's mainly located in T1, T2, T3, and fusiform gyrus. So in this case, again, we open the dura, we identify T1, T2, T2 very insufflated. So we start our debulking at that region, and we then try to identify our anatomy. So we are moving now subpially towards the inferior aspect, that's T3. So this is the fusiform gyrus. Sorry, it's in Spanish and the quality of the video is not so good. And this is temporal horn, which is covered now with this cotonoid in order to preserve the Meyer's loop. We are moving basally to remove the most anterior aspect of the parahippocampal gyrus and the fusiform, which is coming out right now. So this is the parahippocampal tumor, gyrus, sorry. That was again the temporal horn. We are moving now to the ancus, and you can see how the ancus is completely herniated into the crural and interpeduncular cistern. So we are using the QSA in order to remove it. This is the head of the hippocampus, and this is the amygdala. This is the third nerve and PCOM. So that's where the amygdala was being pushed, the uncus being pushed, P1, P2, and finally we took part of the head of the hippocampus. This is the post-op, and this is what I was doing during surgery, just observing our chief resident, Dr. Enrique Luna, who indeed is becoming a neurosurgeon next Friday. So this is my thanks to him for his hard work and commitment during the last 5 to 6 years. So this is the post-op image, and this is very interesting. As you can see, we cut the temporomesial area at this point, at the point of the inferior choroidal point where the anterior choroidal artery is entering. So this is the hippocampus and parahippocampus. And this is interesting because this is one of the limits for the supracerebellar transtentorial approach in my hands, but I know Professor Ture can even read the amygdala. I have seen that, and I guess we will see it later on. But this tumor was growing towards and till the amygdala. So this is the ancus, and we can make this pyramidal draw. So the anterior aspect is mainly related to the amygdala, the posterior aspect mainly related to the head of the hippocampus. And if we have this basal view, we can understand this much better, as this is the dentate with the head of the hippocampus posteriorly. This is the ankle recess, which is the limit, the ventricular limit between the amygdala and the hippocampus. And generally, this is a good limit in order to separate what kind of approach we want to do. This is an 18 months baby, which came with very uncomfortable seizures in 2014 to our department. And this is a very special tumor, which is mainly growing, as you can see, in 3 different areas. So it's growing in the temporomesial pole, also in the amygdala, and in the head of the hippocampus. So this is the area of interest, and these are some important fibers we want to preserve in this case. Meyer's loop. So once we are reaching the most posterior part, we should pay attention not to go too superior and to enter the temporal horn from below. So again, pterional craniotomy, opening the fissure. This was 7 years ago. I have not experience, and in some cases I still don't have it, to go to Transylvian to reach this tumor, but I found very safe to go transplanum polare, and in this case transsuperior temporal sulcus quite anterior. So if we cross the superior temporal sulcus quite anterior, we directly reach the temporal pole, and then we move posteriorly to the amygdala sequentially, and finally the head of the hippocampus, which is exactly what we are doing right here. So this is the third nerve. It means that this is the amygdala. We are moving posteriorly and superiorly to try to find the very difficult limit of the amygdala. And this is the head of the hippocampus. It is a post-op. I saw the patients of this 9-year-old girl this morning, and they told me that she is doing great, no seizures, no anti-epileptic drugs, and this is the most recent post-op MRI. So amygdala, septal region, also they are quite far in anatomical terms. They are very close in phylogenetic terms, and indeed we have something very important, which is the stria terminalis connecting them. This is the last limbic belt I will share with you today. Stria terminalis connecting the septal region and the amygdala. And let me finish with two very fast and fresh cases. I did this case last week. This is a 47-year-old man who came with seizures, and this is the net, which is located exactly in the amygdala. So as you can see, is in the anterior aspect of the uncus, and the head of the hippocampus is pushed posteriorly. So this is mainly a limbic lobe tumor. Important fibers to know and to try to respect. IFOF, especially as we said before, in the dominant hemisphere. So we have to try not to go too superior related to the element insula. And once we enter the amygdala, which is number 1, we should try to respect these IFOF fibers and the optic radiations, and finally get into the head of the hippocampus in case we need to control some seizures. So this is how I did this case. I will show you. I did a small corticotomy in the most anterior aspect of T1, and then through the planum polare, I reached the temporal pole and the amygdala. So this is the left pterional craniotomy, and this is the left sylvian fissure. We are releasing CSF starting by that maneuver. That's a carotid. So we are placing now the electrode in order to continuously check the corticospinal tract. We leave that one in the motor area, and we are using an intraop electrocorticography for research purposes. These are the spikes we found in the first 15 minutes pre-resection, and then we start to split the sylvian fissure to go as deep as we can, but this was a quite complex anatomy full of connections. So I tried to give my best. That's the inferior aspect of lumen insula, but finally I did this small corticotomy in T1, but it was very good in order to orient myself with the ultrasound and with the bifurcation of the MCA. This is the temporal pole already, so the tumor is invading that region. And now sequentially, we will go again from anterior to posterior. So that's the tentorial incisura. That's the third nerve appearing there. So this is the uncus and the amygdala, what we are resecting right now. That's P2. So we want to reach the inferior choroidal point posteriorly. That's why we will be following and trying to identify anterior choroidal artery. That's the uncus, subpial resection of the uncus, and we want to enter the temporal horn. That's the anterior choroidal artery, which is a very good landmark, as you can see here. So we follow it posteriorly to the inferior choroidal point. And here we have the choroid plexus. We remove, in this case, the head of the hippocampus. And after this maneuver, it was very nice because we could find that the spikes completely disappeared after removing the net. So this is the post-op MRI in which I can see that I'm very happy, quite happy with the resection of this completely benign tumor. The patient is seizure-free only 1 week after. And this is the last case I want to show you. Indeed, this is very fresh. I don't have the post-op. We did this case yesterday morning before the webinar. And this is the same story. This is a glioma which was growing since 2019, slowly growing and causing very uncomfortable temporal seizures to this patient. And it's a tumor located in the amygdala. As you can see, purely amygdalar tumor. The hippocampus is completely free of that tumor. Something important I want to highlight, we have been talking about longitudinally oriented white matter fiber tracts. The belt-oriented limbic circuits, and we have to introduce now the anterior commissure, which indeed is running parallel and perpendicular to these fibers. So here we do have the anterior commissure connecting both temporal lobes, temporobasal lobes, and the amygdala. And many of these tumors are spreading to the contralateral amygdala through this anterior commissure. That's why we can find in the EEG bitemporal activity. And this is the commissure which is connecting not only the temporal lobes, but as you can see also the amygdala and the temporomesial structures, as well as the renal regions. And this anterior commissure is a pallial commissure which is present in all vertebrates, different to the corpus callosum, which is exclusive of placental mammals. This is a dissection from my time in Istanbul in which we were able to find this anterior commissure connecting both septal regions and bilateral, the temporal lobes and the amygdala. This is the a view from the inferomedial aspect of the hemisphere. So this is the rostrum of the corpus callosum, and this is exactly the midline. So this is where the tumor is located. I don't know if you can see this anterior commissure. This is the area of the anterior commissure, and in this dissection from the right side, we can see after opening the anterior commissure how these small fibers are connecting both amygdala just at the level of the diagonal band of Broca, which is just below this one. So in this case, yesterday we decided to try a Transilvanian approach in order to resect purely the tumor, to do a purely tumorectomy. So same concept, we open the anterior aspect of the fissure, and we try to identify M1 because M1 was a long one in this case. Here we have it, and it's giving us the relative location of the Limen Insula and the perfect entry point to the amygdala. So we take as much time as necessary opening the fissure. And this is a very, very early anterior temporal branch, which is something quite normal. And I guess I thought this was a good area in order to start the corticotomy. So I placed a cottonoid there, and we had a look with the ultrasound. And we realized that exactly we were quite close to the anterior aspect of the amygdala. So this is the cottonoid, and this is the tumor. So we just needed to do a small corticotomy posteriorly. We place again our grid in order to check what's going on during the resection. So we did the corticotomy right there in the most medial aspect of the planum polare, and then we entered the tumor, which was quite easy to remove, but we at some point used the CUSA. So again, we want to orient ourselves, and this is the most basal and anterior aspect. This is the uncus already, so we are pushing subpially the uncus. We have the third nerve, which will be appearing right there. This is the carotid bifurcation, which means that we went quite anterior, and we want to go posterior now to see the choroid plexus, because it will mean that we reach the head of the hippocampus. And the most difficult part, as we don't have an anatomical orientation, is the superior aspect, which I don't know any specific rule in order to reach that area. And I guess it's a matter of experience. And this is the subpiral section of the amygdala. We are moving now posteriorly, and here we have the hippocampal head. So that should be Meyer's loop, moving posteriorly. This is the choroid plexus, and this is the head of the hippocampus, which was also removed. So that's P2, and that's the midbrain. And we were quite happy with the resection. I'm sorry, I don't have the post-op MRI. Indeed, it should be being done today, but the patient is quite fine. No seizures by the time. And this is my just slide. I just want to summarize that it's meant you have to spend as much time as you can in the lab. I try to do it as much as I can here in Alicante, and study the individual anatomy for each single case. Think on the fibers to be spared. Think on the fibers to be transected, especially in tumor-related epilepsy. Choose the best approach in your hands, always in your hands. And if you don't feel confident with a case, refer it to someone who can do it better. I do it routinely, and I feel very well because this is the best for our patients. Let me finish with this. This is a fish with a very thick anterior commissure. Two neopallial guys, neocortical guys, are trying to hunt it, but he can get rid of them thanks to the anterior commissure and to his rhinencephalum. And this is a fully neocortical guy which wants to get some money illegally from the bank, but he lost his gun, and always the anterior commissure is there to save his life. So that's all. Thank you very much. I hope you enjoyed it, and I'm open to any comment.
Thank you, Pablo. That's a wonderful talk, and even it's tempting for someone like me to take up epilepsy surgery. Such a clarity of topic. And I would like to ask one of a panelist to comment and ask some questions on Pablo's talk, and Roy and Professor Strauss I can see on the screen, and Professor Uga Toure. Any comments or talk, or anything to clarify? Yeah, Igor.
Yeah, hello, Pablo. Thank you very much. It's very nice to see you. A splendid lecture. As always, you have this special way of bringing anatomy to your work. Could you please comment on the definition? Because as I understood well, you don't include cingulate gyros when you say limbic lobe. So I was a little confused. Please comment on that.
No, thank you, Igor. This is coming from Professor Yasser Khil's book, and I do agree that the cingulate is indeed the main core of the limbic lobe, but attending to the organization of the neurons on the cingulate, it belongs to a more evolution area. But yes, it's part of the limbic. Also, in that text, it was classified as the paralimbic structure.
Yeah, I think there is a difference to be done then between the limbic cortex and the big lobe. Yeah,
you're right. Thank you, Igor.
Thank you, Igor. Professor Giovanni?
Yes. Well, compliments for this wonderful presentation. I think that you stress one point, very important. Also, in tumor resection, the intraoperative corticography is very, very important. I think that if you lose 10 minutes to do it, is more safe for the patient. So thank you for underlining this particular neurophysiologic aspect.
Thank you, Giovanni. Thank you. I
Roy,
agree with you.
say something, Roy? Unmute yourself, and can you unmute, Roy? Yeah.
Yep. Thank you, Pablo, for an excellent talk, and I have no questions to you. It's really clear, and how you bring it to life is remarkable. And I think the main message of your talk, which young people should realize, is there's nothing more important than anatomy, and in this case, physiology, as with respect to the epileptiform activity, with respect to tumor surgery. There's a lot of emphasis in the last few decades on images and augmented reality and image-guided surgery. But I think we should stay with our roots of anatomy and physiology to do this kind of surgery in the best way possible.
Thank you.
Can I ask a question?
Yes, please.
Pablo, that was a really enjoyable talk. Quick question. You know, the goal of this surgery in a lot of these low-grade tumors that present with seizures is not just to take out the tumor, but to stop the epilepsy. And there were some cases you showed that had infiltration of just the head of the hippocampus or the amygdala. In many of those cases, particularly on the non-dominant side, I would have recommended removing the entire hippocampus because that residual hippocampal tail can be epileptogenic on its own. Have you followed a lot of those patients after just doing lesionectomies, leaving part of the hippocampus behind to see if they're indeed seizure-free? And why did you choose to just do a lesionectomy there and not remove the whole hippocampus?
Thank you. And I was almost sure that this point would come to the discussion, and I fully agree with you. I don't have a long experience. I started my practice only 8-9 years ago, but I have seen some of these patients in which we tried to remove the anti-epileptic drugs, and we couldn't do that, probably because we were not quite aggressive removing the hippocampus. And the main reason why I am not doing that is because I'm limited by my approaches. If I do that, probably I will start damaging some other fibers, and it's some point a matter of not having enough space in order to reach the posterior aspect of the hippocampus safely with a Transylvian approach or an anterior polectomy, because I'm scared of damaging the IFOF or the optic radiations. So that's why in most of these cases, I was not able to reach the posterior aspect of the hippocampus. That's why, but I fully agree and I appreciate your comment.
Yeah, because the goal, of course, is to stop their seizures. And if they still have seizures afterwards, some people would trade a little quadrant defect in their vision for seizure freedom.
Thank you. I think that's great talk and great comments from the panelists. And